Okay, so I'm going to just go over the discectomy, corpectomy, uncinate resection, and anterior osteotomy. Here are my disclosures. So just one word about the anterior approach. You know, I think you could develop the planes multiple ways. I think Brian mentioned about using the Raytech, which I think is a great technique, but sometimes if your hands are like sort of rough, you could end up getting a bunch of bleeding because you'll kind of tear some of the venous blood supply around there. So I prefer to do my dissection with the Metzenbaum, and then also this is just demonstrating cutting the pretracheal and the prevertebral fascia. And once you get under there, you could kind of split that, and that just right there, the cervical spine is right in front of you. One additional thing is also I do mark the level the same way with the tonsil, and sometimes I have to take my fellows through this approach. And basically what happens is they end up biting it not in line with the ALL, but in the other direction, which doesn't make a lot of sense because you have to bite it. Kind of the fibers are running this way vertically. You have to bite it this way. You can't bite the tonsil that way, otherwise it'll fall off. And that's sort of a real-time anterior approach. I mean, you could. I think it was like a 37-second thing. I tell my fellows by the time they get done with the fellowship, it should be a 4-minute exposure maximum, from incision until localized. One other thing I do in regards to the setup, actually, you know, I'm a little bit younger than Brian, so luckily, I just listened to him give this talk. I'm going to start Trendelenburging the bed because, you know, I'm a little bit younger, so I could operate like this right now, but I have noticed a little bit that my neck's starting to bother me, so. But one thing is also, I mean, sometimes at your respective institutions, you might run into issues with radiology technicians and whatever you're going to practice, and you're waiting for them 15 minutes. And it's the most frustrating thing. So what I did is I just put the C-arm and I drape it in. You could unlock it, you could bring it down to where you need to see it, you could push it up. You don't need anybody, and if you need to press the button to take a shot, you could just ask your scrub tech for a Kelly, you just press it and then you just throw it off the field. Makes things a lot easier in case, so you don't have to wait for a radiology technician. So some of the things I'm going to talk about here are tips for common problems that you see. So how many of you here are residents? How many of you are fellows? So one thing I would say is if you guys are in your training phase, can I get a raise of hands of how many of you have held a retractor watching your attending do the case for the entire case? Raise your hands. That's like everybody, right? So one solution to that is you could use the weights that Brian was saying, but one thing that you could do within the surgical field is you could place your clasp bar pins slightly towards the assistant. And then what happens is you have your V-Mueller retractors in there and you leave one of the handles on the assistant side. And when the clasp bar pin distractors go down, it hits that handle and it holds everything in position. The other tip about that you have to know, and maybe also, Brian, for the weights also, the side, so if you're doing a left-sided approach, the side of the blade towards you, towards the first for the attending side, that blade has to be a little bit longer. Because if it's the same length, that one has a tendency to fall off underneath the longest. So one should be the standard length, and then just pick one size long, 5 millimeters longer, to get that whole system to work for you. Problem number 2, identify the uncinate to identify your midline. So, you know, it's kind of along the lines of what Brian was saying, but if you do this every time, you will get an excellent decompression, and then you'll be able to check it, and you'll also be able to place your plate exactly where you want it. The thing about the discectomy itself, so I've been tasked to talk about the procedure. When it comes to the discectomy, a lot of the times when I take my fellows through the case, especially the first few times, they're very pituitary happy. So you just start, you know, as soon as you make an anelotomy, before I even look back under the microscope, my fellows have a pituitary in their hand. They're just trying to go after the disc. And I think there's a lot of wasted movements there, because if you do a nice 15-blade annulotomy, and you guys will see this in the lab, maybe we should try one level where you do the 15-blade annulotomy first, which means you make a transverse incision on the superior portion of the disc space and then the inferior, and then you make a up and down, sort of just poke it in right where the uncinate is. It's a safe maneuver as long as you don't go deeper than the length of the blade, because, you know, if the person is a very small vertebral body, you could accidentally puncture the dura or cut the spinal cord, which would be a nightmare. So you just have to be cognizant of where that blade is underneath the microscope. But when you do that and you make those 4 cuts, you'll see, you just take your pituitary, maybe I use like a symmetry curette, like a 5B Codman. You make one swipe in the inferior end plate, superior end plate, and the whole disc comes out like a pathology specimen, like circular. If you don't do that and you don't make the cuts and you just go in there with your pituitary first, you're going to be doing a lot of pituitary action, a lot of curetting, a lot of pituitary, and it just becomes a lot of wasted movements. So refrain from your pituitary instincts when you're doing these cases. And also when you use the curette, I always tell the fellows this as well, you cannot have the tip of the curette facing the end plate ever. Because if you do that, you're going to gouge the end plate, you're going to ruin the end plate and the integrity of it, and you'll probably get a high incidence of subsidence. So what you do is, if the curette is shaped like this, you want the sides of the curette to be doing the work. So if you want to angle it, you can angle it a little bit like this, a little bit like that, but never this way or this way where it's directly facing the end plate, because that is going to lead to some issues when it comes time to preparation. So next is the corpectomy. So this is sort of a standard setup that I have for a corpectomy. So I put my Caspar pins in above and below 2 levels to span the 2 disc segments. And then basically do a quick annulotomy with a 15 blade. And once you do that, you sort of have this sort of vertebral body right in the middle. The vast majority of people, that vertebral body is like the perfect size of a regular rongeur. So you put it down, you just bite. It's really like 4 or 5 bites, and you basically get the whole body out, and you're left with a little bit of a thin film in the back, which I usually use a burr for. Just because a lot of these cases when I'm doing this, there's OPLL or there's some significant posterior osteoclasts that go high up. So I'm going to use a burr in the first place. I'm not going to use a rough instrument like a Kerrison. I mean like a rongeur. So that there is a full-size rongeur. It's not a narrow rongeur. So make sure you're using that. And it also helps you to have really nice round pieces of bone graft at the end that you could put into your cage and span the segment to achieve your fusion. A lot of things also, I think this is a time save. If you're trying to say, well, what size cage do I put in for this patient? I tend to use the traditional harms cages still. What I would say is you could use your cervical plating system, take out a plate of given size, see what hits the end plates once you take a little bit of tension off on the Caspar pins. That tells you the exact size of the plate. It gives your scrub tech something to do while you're doing your decompression. So they'll find a cage that height in the back table, or they'll cut it to that size, and then they'll start stuffing it with the bone graft that you gave them when you bit the corpectomy from the rongeur. When it comes time to the central decompression, you can see on the upper right, I use a 2B curette usually, or maybe a 1B depending on how much core compression there is and the type of pathology. But you sort of develop the plane, and once you do, sometimes it all kind of comes off. You could use a pituitary on one side to hold it open, continue to release the scar, and then use a Kerrison to bite it away at the end. And then I sometimes will use 2 cages just to have more surface area for support while the construct is healing. Sometimes corpectomies can be really useful for lower cervical approaches, like C7T1, when the manubrium is a little bit high and it's kind of borderline whether or not you could achieve it. Mostly it's because you could imagine for C7T1, you have to be able to visualize the foramen, and it's going to be hard to do when the manubrium is in the way. So one thing I like to do sometimes is you do a corpectomy on one side, because once you do the corpectomy and you remove the body, you could all of a sudden see the entire foramen. So the indications for me to do a corpectomy are pretty low. I mean, a low threshold for doing it, especially for multi-level constructs where you could get good autograft bone to achieve fusion, and also for decompressions that are lower down, because doing the corpectomy this way will give me enough room to also place an allograft on the other side. So you're kind of optimizing all possible avenues for fusion through the construct. Now let's go to something a little bit more exciting, which is uncinate removal. So if you look at the anatomy of the cervical spine, the uncinate kind of comes up like a smile. So you take a burr and you just really follow that straightness, the parallelness of the end plate, and you go and you make that uncinate base super, super thin. You have your Penfield 4 protecting the vertebral artery there. And once you make it thin enough, you could just kind of flick that fragment medially, remove it with a pituitary, and that's it. That's your uncinatectomy. So very straightforward to do as long as you take the necessary precautions of having your Penfield protecting the vertebral artery, and then using the burr at the critical areas based on the anatomy to be able to achieve that in a very straightforward way. I like doing uncinetectomies. I have a low threshold for doing them because they're straightforward. You can get them done quickly, but patients sometimes will say, I still have a little bit of arm pain. Say, well, I'm pretty certain there's nothing there. And the post-op MRI for them looks excellent as well, as opposed to cases where you're kind of hemming and hawing about taking that uncinate. It may not always be the case. Next, we're going to anterior osteotomy. So the word about anterior osteotomy is essentially the same thing that you saw for the uncinate removal, except you're going to do it on both sides. And one of the most important things about that is a lot of the times you're doing it in cases where you have prior fusions. And what I would say is, as long as you're planning to do a front back, there's very few situations that I could imagine where you have to go back front back. And the reason why is because once you take both uncinates, you could do this sort of maneuver where you could push the head down, remove successive pillows that Dan Rue talks about after the anterior osteotomies, but that's not always possible because if there's metal in the back or rods that are there that are not broken, or if there's solid fusions there, you may not be able to achieve that. But even if you can't achieve that, I want to show you a case here where obviously they have instrumentation in the back of their neck, but this was just a front back operation. So the patient before had like 24 degrees of kyphosis from C2 to 7, and you can see post-op they have like 7 degrees of lordosis. And basically you could see what I did there is I looked at sort of the apical segment, which was like the, I think the C5, 6 level. I did an anterior osteotomy sort of in that somewhat kyphotic position. I put an allograft strut cage in there, sort of centered it, because that's where I'm going to hinge off of. You don't want to put it too anterior in these cases. You put it kind of towards the back of the vertebral body. And then I put a screw in there. You could put a buttress plate if you want, but in this particular case, I don't know why, but I just decided to use a screw up and down to kind of hold that allograft, prevent it from slipping forward. And then when you go in the back and you do a release, like a complete Smith-Peet of the facets, that level is so mobile. Like you could generate a ton of lordosis through there. I almost never do cervical PSOs anymore because of some of the experiences that we've had through the ISSG and Chris Ames. And I have at least 3 or 4 cases where C7 PSOs go completely, like unremarkably. You're feeling great about yourself, and then all of a sudden, post-op day 4, the patient's like, I can't move my fingers. And it's like the most frustrating thing because you image them up and down, you try to explore the area, and then they develop this sort of C8 issue. So I've tried to go away from doing cervical PSOs. More of them are lower down in the upper thoracic spine, T2, T3. And then if I'm doing something cervical, I stick to something like this with the anterior osteotomy combined with the posterior column osteotomy at the same level. So that's it. Thank you.